welcome to the last CSCC Education Roundtable for the calendar year 2015. Our topic today is contemporary concepts in quality management of analytical performance, with Ed Randall as our speaker. Welcome to Ed.
Thank you, Lynn.
I am Lynn Allen. I'm the moderator for this session today. I am a member of the Education Roundtable Committee, and I also chair the Working Group on Quality Management, a CSCC working group. I just want to remind you at this point that when you have questions at the end, you have the chat feature for asking questions, or you can also ask questions orally by unmuting your line, *7, and asking a question. So in terms of an overview of what we're talking about today, Ed is going to be focusing on strategies to define analytical performance goals and describe how these are applied in designing an effective quality control program. And also he's going to review sources of analytical quality specifications. The specific objectives of his presentation are on the CSCC website, the invitation to this conference, and also in his presentation. So let me introduce Ed Randall now. Ed is the Division Head for Clinical Biochemistry at Eastern Health Authority in Newfoundland. He's a Professor of Laboratory Medicine at Memorial University and Team Leader for the Laboratory Reform Initiative in the province of Newfoundland and Labrador. He has a strong personal interest in quality management, and he is a proponent of greater use of risk management in our lab practice. He's also a member of the CSCC Working Group on Quality Management, and in fact, he's my right-hand person in this group. So Ed, thank you, and over to you.
Okay, thank you, Lynn. Hope everybody hears me okay. Please excuse the accent. I drop H's and add H's, so if we can overlook that, I think we'll all be fine. First slide here is one I've used before on a talk on quality control to technologists in our labs. And I don't think any of us want to be this particular person, but as a leader in a laboratory, we don't have to be experts at everything, but I think it's important that we do be knowledgeable of most things that pertain to our area. And I think that's where I would define myself, especially with regard to analytical performance right here. I'm definitely not an expert. For expert advice, certainly there's books written on some of the topics I'll be covering today. But hopefully I can provide you with an overview and maybe inspire you to dig a little bit deeper into analytical performance and maybe doing a better job in our labs at controlling our tests. I have no financial relationships to disclose, and the learning objectives for the session are described up here. And of course, I think they were circulated previously with the notice to this talk. First of all, let's start with the definition of laboratory error. And this comes from an ISO task force group, 22367, back in 2008. And it describes laboratory error as failure of planned action to be completed as intended or use of a wrong plan to achieve an aim, occurring at any part of the laboratory cycle, from ordering examinations to reporting results and appropriately interpreting and reacting to them. Now, when we think about laboratory error, we usually think about it in this particular context here, pre-analytical versus analytical versus post-analytical. And of course, the thing I think that we concentrate on most as clinical chemists is the analytical phase. And I think we're all aware that this is probably the phase where fewer errors occur and more occur in the pre-analytical phase and post-analytical phase. But it's certainly not free of error, and we all know that some tests are much better than others in terms of their performance. But for most of the talk, I will be focusing on the analytical phase, but towards the end, we can delve into some of the other areas. Now, the common approach in dealing with analytical performance and the current paradigm is that of total allowable error and total error. Total error, of course, is the error that exists within the analytical system we're concerned with, and total allowable error, again having several different names and several different definitions, ideally should tell us something about the use or the need for the test we're using, and appropriately, according to this diagram, have some kind of physiological context associated with the physiological process that our test results are expected to contribute to understanding of. But if we look at the variability that exists and that help compose the different error concepts, there are a variety of different types. Looking to the left of your screen, we can see a graph plotting creatinine values against individual patients. Here we're looking at biological variability that exists within particular individuals. And this helps conceptualize the differences that exist in homeostatic set points from one individual to the other. But it also shows us that the range of values about that set point can be different from one individual to another. Coupled to that, and often required to be considered when interpreting laboratory results, is the effect of laboratory bias and imprecision into the entire mix. As we add each element of variability, of course, we get further and further away from that true target value that would be of greatest value in clinical decision making. But analytical error and analytical performance, of course, is a very clinically relevant topic, certainly if we consider the effect that accuracy and imprecision has on clinical decision making. In the diagram in front of you right now, we just explored two possible uses and the relevance of analytical error in this context. Bias has a great effect on diagnosis, especially with the use of reference limits, where a positive bias, of course, leads to possibly more patients having values above that upper reference limit, or if there's a diagnostic cutoff, a positive bias results in more patients being classified in that group of patients that the cutoff is meant to identify. Considering the situation for monitoring, whether it be therapeutic drug monitoring or monitoring electrolyte status or blood gases, imprecision becomes an important factor, which is added to the biological variability, and certainly has an impact in determining what change represents clinically significant change, when knowing that change is important for decision making. Now, imprecision and bias are descriptions of types of variation occurring within our analytical system. Imprecision defines random variation, and it's caused by various instrument factors, factors related to maintenance of an instrument if the test is being done by an instrument, the nature of the quality control material. But we all know that we try to assess random error or measure random error of our methods by looking at the standard deviation or the coefficient of variability. Bias is an estimate of the systematic variation or systematic error in our system. Ideally, bias should reflect a deviation from the true value. Often, however, we don't know the true value, and we measure rather relative bias relative to some kind of group mean, which we assume to be closer to the truth based on external quality control or by other means. Bias shows its face in our quality control by two means. Number one, by shifts in results. If there's a sudden change in the system and the mean suddenly moves in one direction or the other, that's referred to as a shift. Or trend over time, which can be maybe a little bit more difficult to detect, but looking at QC data chronologically, you can certainly see trends developing on occasion. And the things that cause biases are different from things that impact imprecision in most cases. And like I said, trends or shifts in performance are often due to changes in the instrument beyond a certain point in time. Now, both of these elements of total error are brought together and used to determine total error in this calculation we're seeing right here. And the Z value that's used in this calculation most often is the 1.65, and it's based on a probability of 0.05 of values outside this limit. And this calculation of total error, usually expressed as a percentage point, involves multiplying the imprecision, or the coefficient of variability, by the Z, and adding this to the bias, or the absolute bias, expressed as a percentage point. And like I said, the bias is usually determined as a relative bias relative to the method's performance to some reference method or group mean. Total allowable error is basically the standard by which we determine if our total error is acceptable for use or not. And most of us are familiar with this hierarchy of strategies for identifying that performance standard. Coming out of a conference back in 1999 in Stockholm, where the hierarchy of different quality standards were categorized. And as we move down this list from analytical performance based on outcomes in specific clinical settings down to goals based on current state of the art, we move from high quality sources, if you will, or goals, to a lesser quality. Now, back about a year or so ago in Milan, there was a reevaluation of that five-fold hierarchy that came out of that Stockholm conference. And this led to this particular consensus hierarchy. It involved the simplifying of the entire group down to 3 from 5, but at the top again was quality specifications based on clinical evidence, followed by biology, which is basically in the form of measurements of biological variation, intra and intra-individual variability. And at the bottom again is that based on technology or state of the art. And for those of you who are interested in seeing the work that came out of this conference and maybe further work, as the work of this group is continuing now in various work groups, you can consult this particular website listed at the bottom. You'll find a wealth of different resources there. But in terms of technology driven, and I think this is one that we use very often as a source for our quality specifications, and that's state of the art. According to this consensus conference in Milan, this one best suits analytes without a central diagnostic or monitoring role, and for analytes where there is not great homeostatic control. Now, the documents I read were relatively vague in terms of where we can find the sources of these, but I think we can safely assume that exploring conveniently available data, such as from PT programs and external quality assurance programs, that will remain the main source of information for determining what that state-of-the-art goals should be. Big problem, though, with this particular source is that it's not particularly scientifically sound. It's often based on old data. It's non-objective, and it's certainly got an industry bias. It's as good as instruments are made at the current time by manufacturers of devices or developers of kits and so on. There's somewhat of a lack of transparency in terms of how these goals are developed. and they are not related to medical need, or there's certainly not an obvious relationship between how well instruments perform and a clinical need. And of course, many of us may be left scratching our heads, well, how do we get that state-of-the-art standard from these various sources? So what should my precision goal be, for example? Should it be the performance of the best 50% of labs in an EQA scheme? The next level of quality specification are those that are biologically driven. Most of us are familiar with these sources. They are estimates of intra and inter-individual variability, and you can find them listed in a number of websites. Certainly the work of Ricos is summarized on the Westgard website. If you have one of Fraser's books on biological variability, there's a list of these sources of variability and estimates of target or standard deviation or CV and bias based on these particular criteria. However, the Milan conference was rather critical about this one as well, and basically that criticism surrounded a lack of standardization in developing some of the estimates of inter and intra-individual variability. The use of young and healthy people, and the question of whether this data is particularly applicable to elderly and ill individuals. It's very much dependent on the time span of the study, and I guess the argument could be made if the study was carried out over a year or so, would the estimates of within individual and between individual variability be somewhat different? And there was the effect of the measurand concentration. In other words, variability at low concentrations might be different than the variability we might find in an individual with high concentrations of that particular analyte. One of the big problems in practically applying this for laboratories, though, we find is that in some cases it's certainly unachievable with current technology, and there's very little choice in the matter for us then reverting back to maybe state-of-the-art recommendations for quality specifications. The best source, of course, are those based on clinical evidence, and as indicated by the term clinical evidence, that implies clinical outcomes. So outcome studies need to be related to the analytical results for a test in order for us to determine analytical performance for that test and the outcome. Our ability to do that, however, is rather limited, and maybe limited to very few tests, and those would be tests that are central to diagnosis and monitoring disease. Other tests, for example, where you might have liver function tests ordered, where you've got a panel of different tests, who's to say what that performance should be for the ALT portion or the total bilirubin portion, or if albumin is part of that, the albumin portion, because it's really a mixture of all three and maybe more that go into decision making with respect to liver disease. But there are a few cases where, of course, there is that information available and the possibility of developing analytical performance standards based on outcome. Added to this, there's, I guess, the fact that different specifications may be applied to the same element depending on the purpose of that particular analyte, whether it's used for point-of-care testing purposes versus the central lab, whether the test is used for monitoring, its quality specification could be different from that for diagnosis or for prognosis or for some other reason. There's a variety of different calculations for using those available specifications, which adds to, I guess, the diversity of different results and different derivatives of standards that may develop out of this. But nevertheless, quality specifications do have significant value to everyday business for us as clinical chemists. These quality specifications in the form of estimates of total allowable error are useful in deciding if particular tests or examinations are in need of improvement. Certainly useful for us if we're evaluating or verifying the performance of a new analytical method or new equipment. Certainly of value if you apply it to such in developing good quality control programs. It's used by PT and EQA providers to determine acceptable performance limits as well. And of course, these things can serve as targets, especially those that are biologically based and based on outcomes for developing new tests and instrumentation. So we've basically covered the analytical quality specifications, how they are determined, the various sources for these. Now let's take a closer look at how we can apply these specifications to performance goals. Well, if we're looking at those based on biological variability, we can consult a number of sources and come up with estimates as displayed in this particular slide here. For example, if we're interested in measuring the CV, the analytical CV, in precision, Westgard's site, and I think in the book by Fraser as well, they use the following formula, making use of the intra-individual variations. So we judge what's appropriate in precision based on the intra-individual variability. The rationale for that is the lower the analytical CV, the less of an impact imprecision has relative to the intra-individual variability in affecting change. Of course, as you increase from 0.25 to 0.5 to 7.5, defining minimal specifications desirable and optimal, the analytical CV or the accepted analytical CV will tend to have a greater impact on the variability and I guess decrease the value of a significant change in results. Bias, likewise, is defined by the following equations, and again, different specifications are given by sources. Minimum, desirable, and optimal levels are defined. And of course, the compromise there, as a lower standard is accepted, we're accepting the possibility that a greater fraction of patients will be beyond diagnostic cutoffs inappropriately or outside of reference ranges inappropriately during operation of the system. Total allowable error is often calculated based on the intra-individual variability and inter-individual variability in the following formula. And of course, it is available, usually listed on websites that display this data. Now, in terms of deriving performance goals from other sources, state-of-the-art, there's a number of sources. CLIA, external quality assurance schemes, proficiency testing requirements, all of these I think are used by most of us to some degree in developing our quality standards. And applying these, getting direct information about the two types of error again, systematic error and random error. One useful means of getting at that would be to use the error budget. Typically, error budget is adjusted by either a 25% rule or a 50% rule applying to systematic error. Now, if we assume that the relative total allowable error is 100%, if 25% is assigned to systematic error, then 75% of the error that remains within that total allowable error can be assigned to random error. And that component that remains with random error certainly can be further divided up in terms of number of standard deviations. And you'll find various sources indicating either 2 or 3 standard deviations making up the remainder of this total random error budget. For some assays, however, where systematic error tends to be a real problem, there's a practice of increasing that error budget, but it comes at the cost of decreasing the random error budget. So those 2 or 3 standard deviations now must fit within a smaller total error budget, if you will. So the 2 principles I just showed you then are useful at defining the quality specifications for bias or imprecision within the lab. But it doesn't tell us if our particular method is indeed a good method, or tell us directly if the level of quality we're applying to our quality assurance program or our method evaluation study is in fact fit for purpose. That's where I think statistics like Six Sigma come into play. And I think most of us are aware that Six Sigma is not only about Six Sigma metrics, it's about a process as well of continuous quality improvement. But very basically, the Six Sigma concept is based on a scale going from 1 to 6 and even higher. And at each level in the scale, as one increases the level in the scale, the degree of quality measured by the number of defects or errors associated with the process decreases. And of course that makes sense. The errors are referred to as defects per million. So a Six Sigma process would be expected to have an error rate of only 3.4 defects per million opportunities for defect. Arriving at these Six Sigma metrics can be accomplished 2 ways, depending on the type of process we're trying to quantify the Six Sigma metric for. We're most familiar, we would be most familiar with quantitative data. And the great thing about quantitative data, especially when we have the availability of QC data as well, we can measure the variation, the standard deviation. We can measure the bias and get that from our QC and our external QC and PT. Based on that, compared to the total allowable error, we can calculate the sigma metric. For other processes, this won't work. Counting works better. So for example, if we're applying a sigma metric to something that we would count, like the number of lost samples or misidentified samples, then we can determine the metric by counting and then estimating the metric by a scale, by looking it up in a scale that assigns sigma level to the calculated or estimated defects per million based on counts. Applied to quality control, application of the Six Sigma metrics might look something like this. And instead of having standard deviations indicated here, we've got 1S, 2S, 3S, 4S, 5S, 6S. And this, if we were running a Six Sigma method and we're showing the complete Levy-Jennings plot to account for all visible data, and the method was in good control, it would look something like this. So you can see things are grouped around a mean, like the way we'd like to see QC, and very little, if anything, beyond 3 standard deviations or 3 sigma, and 6 sigma, the standard, is way far away, and we're very comfortable with this performance. Now, of course, this metric of sigma metric indicates the position where total allowable error would exist. Sigma can be calculated using this form, and I'm going to tell you that it's useful in determining whether a particular method or instrument is a good one to be using in our lab. It's also useful, certainly, on a day-to-day basis in assigning QC procedures and developing QC programs for various analytes. Some tools you might also find useful in this particular aspect is power function charts and normalized operation specification charts. Now, in using these kinds of tools, it's important to consider that whenever we do quality control, there's two situations exist with respect to that QC result, and there's two types of situations that may exist, or the reality, with respect to the test that we are QCing. That test may be in control, where there is no error present, or out of control, where there's error present. The QC data may indicate pass or fail, but these could be true passes, no error detected when no error was present, but it could be a false rejection, error detected by QC when in fact nothing has changed with the test method at all. Likewise, when error is present, there can be a false pass, QC will be within limits, or a true failure, which is what we hope to get from our QC program. From these terms, we can calculate a probability of error detection and a probability of false rejection. This must be optimized. We want high probability for error detection and low probability of false rejection. This one is a headache. It consumes resources of time and money unnecessarily. So it's important for us to reduce this. But at the same time, we want to optimize this because, especially for relatively deficient assays, those that don't perform that well, we don't want errors in the method to be translated into medical errors in the end. So a balance must be reached by, if we are to carry out a particular test in our lab, minimizing the number of false rejections, but at the same time maximizing the error detection rate. The goals in this particular case for error detection, greater than 90%, this is not always achievable, and reducing false rejections down to 1 in 20 analytical runs or less. So, when being used to select QC procedures, normalized operation specification graphs describe the imprecision and inaccuracy that are allowable for a method and helps determine the QC that is necessary to monitor method performance. And I'll show you that in a little bit more detail in the following slides. But the power function graph determine the probability of detecting an error based on its size. And we can see in this plot of a number of standard deviations against the probability of rejecting a run without considering whether it's a false rejection or a true rejection when an error occurs. A few points are worth pointing out about these power function graphs. First of all is the intercept on the y-axis. This gives us an estimate of the rate of false rejection. As we move towards the upper end of the graph, towards the right and towards the top, this will indicate, depending on the critical systematic error, the power of a QC procedure, if you will, in identifying medical errors or errors, analytical errors in a method. As I pointed out before, sigma is actually part of a quality improvement process. It's not meant to be done in isolation. So once we've defined the quality metric based on the statistical performance of our method, and we've determined what the quality requirement would be based on quality specifications, we then use that to select QC procedures. But the story don't stop there. Then as we use those revised QC procedures, or new QC procedures, there's a continuous process of refining, resolving, and reassessing what we've implemented to further improve and hopefully further increase the number of errors detected and decrease the number of false rejections. Here's an example of a test that, at least in this example, we've determined to be near 6 sigma in its performance. Here's the data all clustered around a mean, and I'm calling this 6 millimole per liter glucose. And we can see that here's the critical systematic error, and this critical systematic error is another useful measure that defines the limits of systematic bias. For example, once we cross this limit, greater than 5% of our observations will be beyond the total allowable error, and we certainly don't want to go there. So it remains as a limit for systematic error within a method. Applying this information to QC selection, of course, different QC programs, if you will, or combinations of QC rules will have different characteristics in the power graph. And of course, we would choose those procedures that are associated with the minimal false rejection and yet maximizing error detection. And it becomes quite easy, of course, when we're dealing with a test that has a relatively high sigma and a very high critical systematic error to work with. Tests like this, however, become more of a challenge. Here we have the situation of potassium, and superimposed here is a shift in potassium results that might result after a calibration or a new lot number of electrodes or whatever occurring. Here in the red, what we expect out of this assay, but it's a 3.3 sigma assay, which means it's right there on the borderline. Critical systematic error is much lower, so roughly 1.5 standard deviations, and things kind of shut down. We've crossed that limit for systematic error. But as you can see in this demonstration here, with that shift, that result goes out beyond the sigma metric, which is of course directly related to the quality specification for the assay. And of course, in this particular case, applying this type of information, we can select rules. In this case, it's a more difficult assay, much poorer in its quality. Therefore, we make up for that limitation by adding more rules, more checks and balances into the process, involving more control values, more rules, but even so, we're tolerating a greater chance of false rejection now and a lower yield in terms of error detection with this. And that's just the name of the game as the quality of the assays decrease. So just to recap on that point, as sigma decreases, so does the level of performance of the assay, and the number of QC rules that are typically required to assure quality must increase if we're to detect medically significant errors. Likewise, as the sigma metric decreases, the number of QC challenges should also increase in order to increase the power for error detection based on those sigma metrics. Now, often internal quality control is not sufficient in itself, and for a number of reasons. The quality control materials we use, we all know in order to have them stable for long periods of time, there has to be certain stabilizers added to the sample, so they do not often reflect exactly what the matrix of a patient sample should look like. So there are matrix effects. The manufacturing process of producing these introduces other sources of variability. Reconstituting these products adds further sources of variability to the results. So it's often a good idea to supplement those routine QC processes with other QC processes. And I've listed some of them here. I'm not going to go through each one in detail, but I'll focus on delta checks and average of normal as two concepts that can be used using patient data that can, in ways, offset some of the deficiencies of our internal QC processes using QC samples. The delta checks are based on using patients as their own controls, and these delta values are based on reference change values. In fact, they can be identical in some cases, but they can be applied to two separate purposes. Number one, to detect significant change in a patient's condition, or they can be applied for quality assurance or quality control purposes to identify possible patient misidentification or other wonky things that might happen in a sample. The calculation of that delta value is based on this statistical calculation. It includes an estimate of the intra-individual variation, so accounting for intra-individual variability and adding in what we know of the analytical variability for the test. Z-score will determine the probability for detection of an error based on significance. So a highly significant change, higher Z-score. Lower significant change, 1 in 20, lower Z-score. A relatively older concept that's now becoming more popular, largely with the availability of new software and middlewares, is the concept of average of normals. Very briefly, the average of normals is a moving average concept where as patient results are collected or analyzed one after the other in real time during analyses within the lab, there's a real-time recalculation of a moving average illustrated in this graph right here. That can be plotted on a Levy-Jennings plot with suitable limits as well assigned, and this can serve as a method in real time, especially for high volume tests and bread and butter tests like creatinine and electrolytes and so on, to detect systematic error. Now, I shouldn't have said creatinine because I'm not really sure if that would be a good candidate for this particular test. But in order to have this working well for you and avoiding unnecessary failures, it's important to filter the data, determine how many samples will be included in that calculation of normal, and a monitoring process. So this is a process itself, probably very time-consuming in setting up and going through several rounds of improvement before we have a product that will work well for us in the lab. But certainly a tool we can use to augment our internal QC. But again, it doesn't work well for all tests, so we have to be selective in how we use it. Okay, so the final section I want to talk to you about now is putting together all of these things into a good quality control system. And of course, there's two aspects to providing good results, and quality, of course, needs to be defined in that product that's acted upon in the hands of a physician or healthcare worker. Laboratory results is what we produce, but producing good quality results involves good analytical systems, so good quality assurance up front in evaluating and validating systems, but also having a good sensitive QC system to support for the long term to assure quality of the system as we move forward. Now, I'm not going to go through each one of these lists, but I'm sure most of us on this call have gone through this ourselves. Good QC practices, starting with selecting control materials. I want to focus your attention, though, down here, that once we've set up that QC program and we've done all the right things, we've done a good job at picking our performance specifications, is to write good procedures and to also communicate that program to the people who's going to be using it on a day-to-day basis. So write good procedures, provide good detailed guidelines that are useful to an individual, for example, in the middle of the night or in a very busy period of the time when suddenly sodium is out of control. What do we need to do very quickly to get at the answers and make quick decisions? Flow charts often help in this regard as well. What to do when, things to check, and so on. All of those helpful aids are important, and I think a part of good QC practice and getting the rules applied the way we want them as leaders within the lab. Going back to some points I raised before with respect to QC rules, I just want to make the point that the rules vary not only with the sigma metric, but also with the type of assay, the type of QC we're doing on a test. In my lab as well, typically in our clinical chemistry assays, we have 2 levels of control. Many of our immunoassays, however, have 3 levels of control. And the types of rules we choose in either case would be suited to the number of controls that would be selected for a run. Going back to the point that error exists in 2 types, there's systematic as well as random error. Some rules are specific for systematic error. Other rules are specific for random error. And it would be important to have a mixture where needed to address both types of errors. But putting all of this together, if we plan our QC procedures well and have our outcomes as close to the medical application of those results as possible in defining medically relevant error, I think we're doing a great job in making our services and our QC practices appropriate for purpose. Now, this involves, I believe, using Six Sigma metrics and using tools like operation specification charts and power function graphs to closely look at, in a more objective manner, what is the predictive power of our QC program and our QC rules at identifying error and limiting false rejections. Now, if we put all of these things together, I think there's still a step further we can go in terms of improving the quality of our operations and identifying medical errors. So I'm going to return very briefly to a point that I brought up in the beginning when we looked at error as existing in 3 parts of the analytical cycle: the pre-analytical, analytical, and post-analytical. A new concept that's becoming, I think, more and more popular, and has certainly led to a CSI document, is that of risk management-based QC. So as I conclude here, I'm just going to very briefly take you through what exactly that means. We do have some experience with risk management procedures, but how do we apply that to QC design? Well, first of all, risk management involves identifying, assessing, and prioritizing risk, followed by a balanced approach to minimize the impact. What this really means is preventing errors that cause harm, but also detecting errors before harm can result. And of course, coming to our minds right now are routine QC procedures, detecting errors before they can cause harm. So risk management QC involves examining the entire process. What that means is starting at the point a sample is being collected and taking it through the entire, taking and tracking that sample through its entire lifetime within our lab, right from collecting the sample to analysis to finally producing results and reporting results in the end. So it's looking not only at the analytical phase, but the entire process. What that means, though, is moving beyond analytical QC results, but looking at other control checks that might be in the instrumentation we purchase. For example, what other checks and balances are designed within the instrument itself to identify possible errors in the process? Are there checks, for example, of the photometers used in our large chemistry analyzers? What kinds of checks are being carried out on a routine basis to affect this? But even moving earlier on in the process, how about the sample collection process? How about the time between collecting the sample, centrifuging the sample? What happens to the sample from the time of centrifugation until it arrives on our analyzer for an analysis? And taking a very close look at all of these aspects and making sure that quality is optimized for all of them. So a risk management approach includes, of course, the test system information about the assay itself. It includes accreditation requirements, consideration of the medical requirements, the allowable error, the context of the test, where the test is being carried out. All of these enter into a risk assessment. Coupled together with development of a process map from start to finish, then examination of the process. And one tool that is often used in this case to examine process for deficiencies would be fishbone analysis. So map the process for possible weaknesses, then the risk assessment analysis. So each identified weakness, assign risk, and once we've identified risk, prioritize those risks, determine how frequent those risks occur or defects could occur, then construct a control plan that would not only address the analytical phase, but also address maybe pre-analytical factors, factors related to maintenance of the instrument, and maybe manually checking optics every now and then if this is not done automatically in some way by the manufacturer itself. By doing so, of course, we improve the entire analytical process, and hopefully with the outcome of reducing medical error. And with that, I'm going to conclude and open up for any discussion. Like I said, I don't have all the answers, but I'm sure with the group online, there's a lot of opinions out there, definitely, and I think a lot of wisdom. So are there any questions?
Well, first of all, Ed, I'd like to thank you for an absolutely excellent overview of this rather difficult topic, at least difficult to present. And I think it gives us a lot of ideas for the challenges that we can investigate in our own lab and to come up with improved solutions.
Okay, thank you.
Are there any questions for Ed?
If there are no questions for me, could I ask the question? One of the things I came across when preparing for this talk was that was particularly interesting, I guess, was use of the average of normals. And I'm aware that a number of vendors provide this as part of their middleware. Does anybody have any experience on use of average of normals and how effective it is in identifying errors between QC challenges, for example?
Does anyone have anything to contribute to Ed's question? Well, if not, we do have a question on the chat line. Ed, what do you suggest we do regarding analytes that end up being at 3S when they're analyzed with a certain TEA and 6S with another?
I think we have to look at what our quality specifications are in that particular setting, and I guess we have to answer the difficult question as well: which quality specification is most appropriate for this test? We always want to move up the hierarchy whenever possible. So if there's good data based on biological variability, then I think that could be the better choice in many cases. However, you got to be careful about that, because if that's a lot broader than your PT program, I don't think there's anything wrong in choosing the greater standard for total allowable error, for example, and maybe using that. So I guess to answer that question, I know I'm not really answering it. It depends on the test, though, and you really have to scrutinize the medical use for the test, and then from the medical use determine what standard would be most appropriate.
Thank you. Is there another question? Ed, I wanted to ask you, for how many tests in your lab are you using Delta checks?
I'm going to give you a rough estimate. I don't know the exact number. It's somewhere between 20 and 30, though.
Okay, thank you.
Hello, can you hear me?
Yes.
Yeah.
Hi, it's Irv Bromberg from Toronto. Can you hear me?
Yes, we do. Hi.
I just wanted to respond to your question about the average of normals. I don't use average of normals, I use medians instead, and then I don't have to exclude abnormal results because the median is minimally perturbed by the presence of abnormals in the data.
Okay.
You mentioned a few good ideas about when you couldn't apply the average of normals, and I could just add another couple. One is in tests where most of the results are negative, for example, antibody tests, where mostly normal people are encountered in the patients being tested. It's not a useful thing because almost everything is going to be negative, and your median or average is going to always be zilch. But similar problem would happen with any test that has a highly skewed distribution where most of the patients are, so it works well with distributions where there's sort of a centralized distribution that has a reasonably Gaussian distribution of patients with numbers that could be lower, numbers that could be high. Let's see. I wanted to ask
I'm going to comment that Lori Beach has indicated on the chat line that a number of the community labs are using the average of normals. And they may be using it for hemoglobin A1C, but I also believe they're using it for other tests in the laboratories.
So the other comment I wanted to make was about the practicality of this. So in actual practice, the technologists are working in a hectic environment, and when the QC starts to go off, they can't really sit down and go through a standard operating procedures and try to make sense of all this math and all the complexities of what's appropriate. And I don't think that it's particularly helpful to have to make the answer to this that you document standard operating procedures and expect people to be able to follow them, because they're not going to be able to do it. It could be a source for study, but not something that could be applied at the bench.
I agree with you totally there. I think the point that I was making was to have what that procedure, whatever it is, well documented in a procedure, but part of that is teaching and training technologists. But what we use to assist technologists, of course, which are very busy in those situations, is to have flow charts and decision charts available for them, which are I think, much better as quick references to use. And I agree with you. People are not going to look for a standard operating procedures when they're really busy. But if you've got a good flow chart that's handy and conveniently available, which they are in our laboratories, it's right up there next to the terminal that they're using when releasing results. I think it's a much better way of delivering that key information quickly.
Well, I get that, and a flow chart can be very useful. It's very difficult to do that well, and in my experience, most people are flow chart challenged. And so I would suggest the thing to do instead is, what's very difficult to do, is to have an interactive computer program that is part of your total QC management package, that it's going to provide the smarts and the advisories, and also should provide educational and reasoning information so that they can follow the logic. But it's very difficult to do that well in such a way that it actually helps and doesn't hinder.
Yeah, that's an excellent idea, I must say. But you had to be, and the thing I worry about with these quick prompts, for example, if a QC test fails, is the advice that we're providing applicable to this particular situation? And we don't see the situations. We can predict what they will be, but whether that's the solution for that particular event, we don't see all the factors, and we certainly can't predict what those factors would be. So I guess in a nutshell, I'm a bit nervous about that kind of thing, just that we might be giving advice that might be good in the general context, but in a specific context that might be bad.
Okay, with that, Ed, I'd like to thank you very much for your presentation today, and to thank the audience, all of the participants in today's educational roundtable. The PD code has been entered under the chat list. It's the third entry on the list of questions, I believe. I want to say that this presentation today supports the quality management program in laboratory medicine that we believe that this will be launching on Monday next week, on Monday, December 14. And this is a program with 5 modules. There's lots of information on the CSCC website on this. In terms of the PD code, you should remember to visit the CSCC website and enter your code so that you obtain your certificate. And this presentation concludes the education roundtables for this calendar year. They will start up again in January. The next education roundtable is January 14, 2016. It will be presented by Jonathan Berg on the topic of harmonization, the UK lab experience. So thank you very much again, and best wishes for the holidays. Thanks.
Thank you.